Today, we're very pleased to bring you the latest in E4C's 2012 webinar series. Today's webinar was developed in collaboration with Engineering World Health on the topic of building technical capacity in resource-poor hospitals. Our guest presenter is Julien Benchetrit. My name is Yana Aranda, and I'll be moderating today's webinar. When I'm not doing this, I work with the American Society of Mechanical Engineers, where I am a program manager in Engineering for Global Development Department. So a little bit about the E4C webinar series and today's webinar specifically, Engineering World Health, Building Technical Capacity in Resource-Poor Hospitals. One of E4C's topical focus areas is health, and we're glad to have the opportunity to address some of the important issues related to this field here today. To do so, we've invited today's presenter, Julien Benchetrit, who is a student programs coordinator at Engineering World Health, to talk about some of the work that EWH has been doing. Julien, thanks so much for joining us today. Before we get rolling, I'd also like to take a moment to recognize the coordinators of the E4C webinar series generally. Myself, along with Holly Schneider-Brown and Alex Torres of IEEE, work very closely to develop the series. Thank you very much to the team, that is, and to all of you. If anybody out there has questions about the series, please be encouraged to contact us via the email address visible on the slide, webinars@engineeringforchange.org. Before we hand things over to Julien today, we thought it would be a good idea to remind you about Engineering for Change and who we are. E4C is a global community of over 11,000 actually now technically minded individuals such as engineers, technologists, representatives from NGOs, and social scientists who work together to solve critical humanitarian challenges, whether in water, energy, health, agriculture, sanitation, or other areas which are faced around the world today. We invite you to join E4C by becoming a member. E4C membership provides cost-free access to a growing inventory of field-tested solutions and related information from all the members of our coalition, including professional societies like EWB USA, Engineers Without Borders, and IEEE, academic supporters like MIT's D-Lab, and international development agencies like Practical Action, as well as access to a passionate, engaged community working to make people's lives better all over the world. Registration is easy and it's free. Check out our website, engineeringforchange.org, to learn more and to sign up. So the webinar you are participating in today is one installment of the Engineering for Change webinar series. This free, publicly available series of online seminars showcases the best practices and thinking of leaders in the field who bring leading-edge technology and solutions to bear on global humanitarian and development challenges. Information on upcoming installments in this series, as well as archived videos of past presentations, can be found on the E4C webinars page, and the URL is right there, engineeringforchange-webinars.org. Just wanted to let you know a little bit about our next webinar, which is going to be with an amazing organization called IDE. The topic is going to be revolutionary. It's a clever title, talking about designing sexy toilets in the markets to deliver them. Our presenter will be Yi Wei, who is a marketing advisor for IDE Cambodia. The date is currently Tuesday, September the 11th at 11, easy to remember time and date. You can register already at engineeringforchangewebinars.org. A few housekeeping items before we get started. So first and foremost, welcome again, and I wanted to see where everybody's from today. In the chat window, please type your location. Let us know where you are joining us from. Any technical questions or administrative problems should go in the same chat window. Feel free to send a private chat to Holly or Yana if you have some specific technical inquiries. You can also use the chat window to type any remarks you may have. During the webinar, please use the Q&A window, which is located just below the chat window, to type in your questions for the presenter. If you are listening to the audio broadcast and you encounter any troubles, try hitting stop and then start. If that does not work, you can use the call-in number for the teleconference. You may also want to try opening WebEx in a different browser. I see some folks already typing stuff in here. Fantastic. Following the webinar, to request a certificate of completion showing 1 professional development hour for this session, please provide your full name and date you completed this webinar, as well as the code that we will give you at the end of the session. Send this to the email address eab-ceuadmin@ieee.org. So let's introduce today's webinar presenter. His name is Julien Benchetrit. Julien became involved with the Healthcare Technology Access projects as a biomedical engineering student at the Imperial College of London. He started out by participating in Engineering World's Health Service Learning Program at the Summer Institute. There, he was trained to repair medical equipment and worked at Hospital Regional Atlantida in La Ceiba, Honduras, placing back into service and training the local staff on just under 40 pieces of equipment in 4 weeks. Julien has been involved in a number of healthcare technology access projects since then, developing a knowledge base aimed at medical equipment technicians in resource-poor settings, and volunteering with an energy access project for Indian healthcare providers, amongst other things. Julien joined Engineering World Health as Student Programs Coordinator in July of 2010. He is responsible for the technology design work at EWH, including the Projects That Matter, Chapters, Design Competitions, and Kits programs. He brings hands-on experience with the technical challenges that face developing world healthcare and numerous technical and communication skills, including web development and fluency in English, French, and Spanish. So with that introduction, I'm going to turn it over to Julien to take over presenting today's webinar.
Perfect. Thank you so much, Jana. First off, I wanted to thank E4C, Jana, and Holly, and everybody else there for letting me talk today. I'm Julien Benchetrit. Jana, thank you for introducing me. I'll be speaking about Engineering World Health. We're a nonprofit that's been around in various forms for about 10, 11, 12 years now. And we do, our goal is basically to build technical capacity for hospitals in resource-poor settings. And ultimately, the simple version of saying that is just to say that we want the doctors and the nurses to have all the tools they need to diagnose and treat their patients. So what I'll do in this presentation is start off by spending a few minutes looking at some of the issues that surround healthcare technology in resource-poor settings. Then we'll switch to looking at some of EWH's programs and the various things that we've attempted over the years, as well as some of the things that we've learned from that. And then finally, I'll have a bunch of pictures at the end, depending on how much time we have left, that I can use to show you a lot of our different projects and things that we've worked in with students in the past. So let's start off. So as of right now, about 80% of the world's population spends less than $100 per head per year on health. And by that I mean the government of that country. I mean total expenditure, not just what a single person is spending out of their own pocket. Oh, I'm sorry, Jana?
Yes?
Oh, I'm clicking on the slides and it's not moving forward.
Just a moment, please. Holly, can you
you should be able to do it. You do have the ball right now, Julien.
I know I'm clicking on the slides and not.
I have advanced it for you. Does everybody see the next slide?
No. Julien, you're trying up at the top, the top right hand
number
corner.
8. Mm-hmm.
Okay.
Yep.
This should work. Okay. All right. And so we have data that shows that in many places, including Sub-Sahara, that figure drops to $15 per head per year on health. The problem is that the equipment that's used in those hospitals is the exact same equipment that's used in hospitals in much richer countries. And because that equipment was designed with those countries in mind and was designed with the budgets of those hospitals in those rich countries in mind, this equipment is just not sustainable in over 80% of the world's population. And so it's just no surprise that equipment fails in resource-poor settings when it was just never designed to work in that setting. And a lot of the following slides will take a more specific look at why that's the case. So as a result, we see over 50% of all medical devices being out of service in most of the hospitals we visit. And again, in sub-Saharan Africa, that number rises to up to 70%. I'll also want to take a look specifically at donations. This is a particularly important thing for us because, you know, we see a lot of financial aid coming through from more developed countries, but it's not necessarily always the appropriate solution. If you take the example of childhood mortality, one of the most frustrating things we know about it is that if we had modern neonatal incubators in any resource-poor country that doesn't have them, we can do something as amazing as divide by 2 that country's infant mortality rate. So, you know, while technology might exist for all these things to happen, you know, if you buy a very, very expensive, you know, state-of-the-art incubator or neonatal ICU and you send it off to a village somewhere in Africa or in Central America, you know, it might work great for a little bit of time, but eventually something will go wrong, it'll break, and ultimately there's a very, very good chance that it'll just remain broken forever. And so that's why we work with technicians. That, you know, the question here is why, and so we see a lot of problems such as you know, you don't have the whole system of spare parts on the ground, you don't have the expertise to fix the equipment, and so you end up with a situation where lots and lots of money is being spent on donations and on aid, but a huge portion of it unfortunately ends up being useless. To look at that in a little more details, actually, take the example of a hospital in, say, Central America, in a coastal city that's receiving an X-ray unit. So that hospital has to pay to get out of customs, then it has to pay to drive it from the port to the hospital, then you pay the workers to unload it, haul it to the room where you want to install it, and then eventually only to find out that maybe you can't install it because you don't have the right plumbing or the right electricity to support it, or the room isn't isolated appropriately. And so because of the bureaucracy involved, a lot of the hospitals that we work with end up not being able to get rid of this useless equipment, and it ends up taking up lots of space that could be used for something else. So it's both space and money that is being wasted for hospitals that receive inappropriate donations. And so that's one of the things we work with some students, working with students and organizations that specialize in donations of medical equipment to ensure that donations are made, well, overall in accordance with the WHO's medical equipment donation guidelines, but some of the specifics of that would be that medical equipment needs to correspond, donated equipment needs to correspond to the needs of the hospital. So we will work with our technicians on the ground to make sure that these hospitals have maintained working inventories with what's working and what's not working, and other things like that. And then so to look a little more at why exactly we see those issues, what are the exact issues that we see, which will allow us to then determine how to best approach with our solution. So these are some reasons that have been highlighted by some of the studies we've looked at. So the first, the first one of them is the mismanagement of the technology acquisition process. If, as I was saying, if a hospital doesn't know what equipment it has, what's working, what's not working, it's not going to be able to tell to the donor what it needs to receive, or it's not going to be able to make the appropriate purchase if it has the funding for that. Then there's the lack of skilled maintenance personnel, the lack of effective technical support. If you may have qualified technicians sometimes, but if you don't have the proper tools and resources to perform that job, there's just not much that they can do. They're missing service manuals and plenty of other things that cripple them in situations where equipment's been donated, or maybe it's not in the right language. There's a number of issues like that. Then there's a lack of consumables. And so consumables, by what I mean by consumables in this case is anything that is going to be used once on a patient in general. You can think of an ECG electrode as an example of that, or a ESU grounding pad. And so the problem with that is that they're very expensive or impossible to find in a lot of the countries where we work, or the countries where work like ours would be needed. And then on top of that, you have the lack of spare parts, which just goes along with it, because in a lot of cases when the equipment is donated, there's no service contract to go along with it that would make sure that there's a steady flow of spare parts as they are needed, and of as qualified technicians to work on that specific piece of equipment. And then on top of that, there's no, on the hospital side, on that end, there's no budget for a lot of those things, the consumables and the spare parts. Very often we see that it exists for light bulbs and small things like that, but very rarely for the larger things. And that's because, unfortunately, the real costs of maintaining medical equipment are very often overlooked. If you look at this graph right here, it shows you that if you buy a piece of equipment, that's only 20% of the expense. If you're using it for 2 years, actually 80% of the costs are, not obvious right away, if you will. And in the end, if you buy a $50,000 piece of equipment and you want to run it in your hospital for 2 years, but you haven't planned that, in fact, you might need closer to $250,000 to use that piece of equipment, then you might be in trouble somewhere along the way. And that's another issue that we face and that we try to counter, mostly through the teaching of healthcare technology management. Then ultimately, this is what matters most. How does this affect healthcare? How do patients suffer because of this? So we see that certain procedures can be performed. If there's no X-ray machine in a specific hospital, it also means that on top of not being able to perform, that hospital is forcing the patient to then go on to another hospital if that's required. So you might need to travel hundreds of miles to get to the next hospital, and then eventually you'll have to go back to the first one for a diagnosis if the other hospital was even able to give you the tools that you needed for your diagnosis. Then we see very often negative outcomes due to some of those things. If you have a piece of equipment that isn't calibrated properly, it might lead to the wrong diagnosis and in turn a wrong treatment, which ultimately is very dangerous for patient safety. There's also infrastructure issues that lead to safety issues. You can see an example of that in the picture on the right. But just to give you an example of my own, I was working in, as I was saying, I was working in La Ceiba, and I went back there last summer as staff for our summer institute, actually, and they had switched hospitals in La Ceiba specifically, and that the new hospital had been designed with an architect that had forgotten to install the proper grounding in operating rooms, and so because of that, the operating staff, so the OR staff, was getting shocked on a regular basis because of those infrastructure problems in the hospital. And just another story, actually, another very interesting one, but a very sad one, unfortunately. We were working in Tanzania, another place where we run the Summer Institute, about which I'll tell you more in a minute, actually. And so we were seeing that in that hospital there was no capacity for cardiac diagnosis. So if you had any kind of cardiac problem, there was nothing to take your ECG or monitor any of those vitals in any way. And because of that, if you came into the hospital complaining with a chest pain or something along those lines, people might test you normally for maybe a heart attack or some other issue, but there, because that was the only option, you would go home with a diagnosis of malaria and just malaria medication. leaving you not much of a chance to recover unless you had by some random chance malaria in the first place. Then another issue that arises out of all this is that efficiency is diminished in hospitals, and that's important because it slows down the hospital, which means in turn seeing less patients, receiving less revenue, and ultimately there's this vicious circle where there's a lack of money means that the hospital can't buy more equipment or pay for more staff, which in turn leads to less efficiency, lower revenue, and so on. So EWH has been trying to counter these issues for a number of years now. We were started out of the lab of Professor Malkin out of Duke University, and one of the first programs that we worked on, the second one, but I'll tell you about the first one in a minute because it works better in that order, is the BMET training program. What I mean by BMET is Biomedical Equipment Technician, and so that would be anyone that is working in the hospital on the equipment, so that it's, basically the person is responsible for making sure that the equipment is always working, and running preventative maintenance and repairing in case of need. So this program began in 2009 thanks to funding from the GE Foundation, and our initial training was, our initial purpose, was to provide, to train 45 BMETs for every single public hospital in Rwanda. And so that's what we've been doing over the past 3 years, and since the program has started. And so the program is focused on repair skills, on healthcare technology management, on professional development for our technicians, and very importantly, on the creation of an indigenous training facility to operate after we leave the country, after our funding has run out, and after our 3-year mandate in the country is over. So this is also the first and only program that educates biomedical equipment technicians and simultaneously creates a long-term solution to have indigenous capacity for the host country in its professional field. And so we have a number of steps that we take to make sure that that's possible, such as involving the host country's government, generally the MOH, the Ministry of Health, public hospitals, and a local educational partner for all the teaching done in the program. And we've expanded this program in the past couple of years to 3 more countries: Honduras, Ghana, and Cambodia, in that order, I believe. So what I'd like to do next would be to present our summer institutes. And the reason that I want to present our summer institute first is because this is the first program that we had, and the summer institute is still running. But basically, what happened was with the first 10 years of the program, we used all the data that we received to create the curriculum that's being used in BMET. So that's why I'd like to introduce you to the Summer Institute right now. So this is a program that's been running for a very long time, I think it's 11 years to be precise, and it's a program that's destined for engineering students currently in university who are interested in a service learning program for the summer. The purpose is going to be to travel to either Central America or Tanzania for 2 months. The first month is language and technical training, so the students will learn Spanish if they're in Central America, Swahili if they're in Tanzania. And the technical training will be, looking at some of the equipment that's available in the hospitals that they are likely to work in, and actually learn specifically the problems that are likely to arise in those hospitals and how to fix them. And then after that, the students are distributed in pairs to our partner hospitals and work for the second month as technicians in that hospital, partnering with that hospital's technicians and staff, and implementing solutions and a number of secondary projects. So would be the summer institute, and so the reason that I wanted to tell you this is because as the students work on their projects, they're asked to keep track of all of their repairs, every piece of equipment that they've touched, whether or not they've succeeded in repairing it or in training the local staff on it or whatever it is that they were trying to do. They have forms to fill out and data that we then collect to build what we called the Biomedical Technician Assistant skills. And so those skills, the BTA skills, they were developed by Professor Malkin's lab at Duke, who is also EWH's founder, based on those 3,000 work orders, and then eventually consolidated to a list of over 1,000 fundamental skills. And so these are not equipment-specific skills. These are very, completely independent of say, you would be looking at an X-ray unit or anything like that. These are skills, these are just everyday technical skills that you can use in any type of repair, and they're distributed in categories such as, mechanical, plumbing, electronics, and so on. And we've demonstrated through various studies that the alumni, people that have received this training, can repair 66% of the devices that they encounter in hospitals of resource poor settings with less than $50 as their budget. And so what I'd like to do next is take a look at, very briefly, some of the results of our initial training in Rwanda. So we started training in 2009, and this is a study that came out, I believe, in early 2011. And it shows a little bit about the impact of our, the changed ability of our technicians after their first couple of sessions training with us in Kigali, and hopefully some positive stuff. So we surveyed 9 hospitals, half of them with EWH trained technicians, half of them without, 5 and 4, and our results were that EWH trained technicians tended to have less out-of-service equipment than the non-EWH trained technicians. So that would be a 35% decrease in amount of out-of-service equipment. And I just want to note here that the reason why the 10% and the 15% numbers that you see here are much lower than what I mentioned at the very beginning of the presentation when I said that 50% of the equipment is out of service is because, very simply, the definition of out of service used for this study is slightly different. We're looking at only equipment that's in the hospital, in rooms that are being used by staff and by patients, rather than just where equipment would be stacked up. And then the second main thing that we found out from this study of our technicians is that they tended to resolve or partially resolve more cases than non-EWH trained technicians, which was a 27% increase in the number of resolved cases. And we've obviously got some, great anecdotal evidence to go along with those things, some very, very cool stories from our technicians, writing back to us and saying that, maybe they opened up an X-ray machine, and, well, actually this one is a real story, of one of our students opening up an X-ray machine in his hospital and realizing that even though this X-ray machine had not been opened in years, because there was simply nobody that had the skills to think that it was in their capacity to repair that equipment. Because that equipment had never been opened, it turned out that there was really no real problem with it. All that needed was a couple of blown fuses to be replaced, and again, overnight, because of that, thousands and thousands of people were being served by this X-ray unit again, and patients didn't have to travel a very long distance to get to their hospital. So that would be for main results. On top of that, we looked at a number of other things when we did this study, and I'll go over some of them a little faster, but look at the conclusion, just so to make sure we can go over everything. This particular example example was about looking at the training that we dispense and whether or not we think that there's a justification for giving equipment-specific training. And what we saw from this was that not necessarily because we didn't see a huge difference in, once we had trained technicians on certain pieces of equipment, we didn't see them a huge ability, an increased ability for them to repair that specific piece of equipment over other pieces of equipment. As you can see, 47.6 versus 50%, so not much of a difference. Then another thing that we looked at, and that's something that we've been very interested in, especially since we started at the Summer Institute 10 years before the BMed program, and that would be the ability to use local resources for our work. And so here we were looking at the reason for not being able to repair a piece of equipment, what was declared by technicians as that reason. And we saw a slight decrease in the availability of materials, so parts in general, as a reason for not being able to repair something. And so we understood from that some of our technicians had the increased ability now to scavenge and to find more parts locally than before. And one of the reasons for that was actually the added communication between our technicians, and there's actually a lot more benefits to that than just their ability to find more locally. There's in-country communication that we studied and out-of-country communication. So our technicians were given a lot of training on going online and seeking help there, asking experts on specific pieces of equipment for further help if they needed so. And so we saw a huge increase in in-country communication and out-of-country communication between technicians that we had trained and technicians that we had not. And so we were very happy to see that, and we got a lot of reports that have helped those technicians in their work. So some of the things that we saw, our BTA curriculum has been effective in reducing out-of-service equipment and resolving cases. There's little evidence to support equipment-specific training and please note that that's only our thoughts in initial training. So we also have a BMed program where we do continuing education, and there we dispense equipment-specific training because there's a certain point where you just need to do that. Then we found that EWH trained technicians learned to identify locally available resources, and EWH technicians use professional communication to repair equipment. And that was a very important one for us because we're really trying to do what's called, build a community of practice for our technicians to also gain, not only to give them more higher ability to do their work, but also to build the recognition for their work within their own hospitals. We've received, again, a number of reports from our technicians telling us that they have been, given more responsibilities within the hospital, more time with other staff. Sometimes they've received, maybe a new workshop to do their work or raises, and so on. And so we're also helping out with professional societies and other things to build up the profession. Now that would be it for BMed, and there'll be plenty of time for questions afterwards. So now I'd like to go on a little more to our program, to our student programs. And actually, no, allow me to just add one thing to BMed before we go, and I think that'll be more relevant to right now. For professional engineers that are interested, we have a number of opportunities available for people to become guest instructors. That typically happens as a 1-week or 2-week trip to our training center in the capital of which, or close to the capital of whichever country we're working in, and it it includes training on all kinds of topics, math, healthcare technology management, and plenty of other things. And so we have survey that you can fill out to express your interest in participating in that. And the link to it is ewh.org/BMETGI for BMET guest instructor. And I'll put up that link again in my last few slides when I recapitulate. Now for student programs, so those are the programs that I'm responsible for personally within EWH. We manage a network of university-based chapters, and that's really the main hub for which we do a lot of work with our students. I was talking about the Summer Institute earlier. Roughly 70% of students that go on the Summer Institute are also students that have been involved with our university-based chapters. And so those chapters, they're here to raise awareness about inequities in global health and inspire our members to apply their technical skills and creativity to work for solutions. We're currently in 6 countries and have roughly just under 40 chapters at the moment. And so those are I'd like to tell you about some of the things that our chapters work on with us, but some of the things that I'm about to list are not exclusively reserved to our chapters. These are just some of the programs that we offer to engineering students in general. So the projects that matter, that's a list of annually updated design projects for appropriate medical technology. We're looking at a list that we update every summer at the end of the Summer Institute because what we do is we receive, again, a lot of data from our students, in this particular case, needs-defining interviews, and we use that data to determine what we think would be the most impactful technologies projects if they were to be developed successfully. And a list is made available online at ewh.org/PTM for projects that matter, and we welcome anyone who's interested in taking over those projects. And what there's previous work that's been done on it, we can actually distribute some of that work, provided that the previous person has agreed to it, and you can take over from there instead of starting from scratch. I'm going to go on straight to another program now, but at the end of the presentation, I'll have a series of examples of some of the projects that are currently ongoing and some of the projects that we've in the past worked on with our huge base of volunteers and others. So the next program I'd like to talk to you about is the design competition. Very straightforward. We're running a program where student teams submit designs directed at the needs of developing country healthcare. Some of the projects that we see come from our Project That Matter list, but a lot of them don't. The Project That Matter list is very traditional projects in a sense. They're really looking at the needs of the hospital specifically, but we see a lot of very interesting projects that are coming out in the design competition that the students have come up with themselves that look at other branches of global health. They look at off-the-grid healthcare. So we see a number of projects along those lines, projects that look at telehealth as well, which goes along with off-grid, and I'll have those examples again at the end of the presentation. Then at the end of the competition, obviously the designs are reviewed by experts. We have cash prizes for the best teams, and then we help them out. We work with them in eventually implementing some of the successful designs in the way that we think is most appropriate for the country's success. Then the KITS program. So that's a program in which we distribute an unassembled biomedical test device, and we distribute it to our chapters. They work either alone or with middle and high school teachers to host kit builds as an educational activity for those students and those volunteers. And so once they've assembled those pieces of equipment, they eventually send them back to us, sorry, and we test them out in our offices and distribute them back to our partner hospitals, to our technicians ourselves, with the hope of partially replacing other testing devices that are worth thousands and thousands of dollars most of the time. Some of the examples of the devices that we have worked on include ECG patient simulators, defibrillator testers. Currently, we have the EWH electrosurgery unit tester, and a number of other projects that we are currently or very interested in working on. There's billimeters and a number of other things, and I'll have other examples in the technology or design projects section of the presentation at the end. That would be it for kits. And oh, actually, my bad. This is the design project portion that I was just talking about. So those projects will be divided along 3 categories, and I see that we need some time for questions as well. So I'll go over that part a little fast, but there'll be times for questions. I'd rather we be able to focus on what you're exactly interested in rather than this rather large section. The first category of projects that we looked at is, as I was just saying, so kits, pieces of equipment, pieces of projects that can be turned into what's traditionally referred to as TMDE equipment. So any equipment that can be used for testing, for calibration, and diagnosis of other pieces of medical equipment. And there's a number of reasons for that. Those pieces of equipment are obviously much simpler than others, so it makes it a lot easier to work on those as pure projects that can be assembled by students of a young age. So to take a look at some of those examples, that would be this particular picture is of the ESU tester, of the assembled ESU tester, of course. And this is what it looks like. So the ESU tester is, as you can see, it's written on the side. It's an electrosurgery unit tester, and there's a number of LEDs on the inside that you can't see from this angle, but that will light up according to the energy that's going through the ESU generator, and then allow the technician to calibrate his device. This is the circuit that we have on the inside, and so basically when you're receiving a kit from EWH, you receive a box that includes all of those parts unassembled, and then it's up to you to put them together. Then this is actually very interesting. Some of our there was a kit build being organized by the students, a team of young biomedical technicians that you see on the left, who actually, as they were working on the build, decided that they wanted to improve the design on their own. And so we're now actually looking at implementing some of that feedback in the U.S. In our office in our current design. This is a design for a billimeter that was developed a few years ago by a team of students from NC State in partnership with us. And this one, along with this previous design, are very interesting because they're both powered by the device that they're testing. So in this particular case, you have a solar cell at the top. I think I can, yeah, right here. So you have a solar cell right here underneath a blue filter that will allow you to then activate the ammeter right here to determine whether or not there's enough billy lights or blue light to degrade bilirubin and thus treat jaundice in babies. And then the same thing here, where when you place the bogey pen or the what's called the bogey pen from the ESU generator, when you place it on this probe, that's what powers the rest of the circuit. As you see, there's no battery or anything in there. Then to go on some other examples, this is actually a brand new design that came out of our design competition this year. It took 3rd place, and this is a reusable device that allows you to, which is the important part, and it allows you to test wherever sterilization is being done appropriately. You actually stick this device into your autoclave, and after a full cycle of the autoclave, it tells you whether or not things have been done appropriately, along with a number of pieces of information. This is a design that we're really interested in working with this team of students, that team of students that worked on it, because particularly it gives us the ability to empower our technicians, to give them the tools, the technicians that we train, for them to have the tools that they need to do their job. There's another project that we want to turn into a kit that we're working on right now, and it's a defibrillator tester. The two golden strips that you see on the right and on the left are where you would place, or copper tape electrodes that you would, on which you would place the Z-tip paddles, and then either LEDs or a 7-second display would then tell you up there at the top what's going on. And of course, we're looking for people, we're looking for volunteers and experienced electrical engineers to work with us and to help us out with some of the development. And so that's another thing, that's another way in which we're looking for people to get involved with us. And you can do that by contacting me after presentation. Now, the second type of project that we have is locally manufacturable solutions. In this case, what we're looking at doing is, instead of actually distributing a piece of test equipment like we did with the first type of project, here we're working with the students to determine that the solution is of high enough quality, and then work on distributing it not as a device, but instead as a set of instructions that anyone can use to build their own version of the solution. So this is one particular example that actually I think E4C is particularly familiar with, because it's in the library on the Engineering for Change website, and it's very simply a set of ECG electrodes that are both reusable and built from locally available materials. On the left, you can see a beer bottle cap. What you do to build those is actually very simple. You'll boil the the caps, and the plastic lining that comes out of it, that you can very simply peel off once the caps have been boiled, is what you use as the electrode. You'll pierce a hole through the middle, put a sewing snap, and that's then compatible with regular ECG electrodes and the lead cables that go along with them. And that's it. This is all the tools that you need to actually build that. The pot in the back for the boiling, the X-Acto knife, the pads, the caps, and the sewing snaps. And the screw might just be necessary to help you peeling off the caps. But if you find the right caps, they actually pretty much come off with just your nail or naturally. This is another such project that we've worked on. This is a part of the instructions that are used to it to show you what it's supposed to look like at the end. And this particular project is used to adapt surge OR lights from one light to the other, because sometimes when if your bulb breaks down and you need a replacement, there's a very, very good chance that if you're in a research board setting, the type of bulbs that you're looking for, because they use proprietary, in a lot of cases, proprietary sockets, you won't be able to find one. So this is an alternative solution in this case. And this just shows you a little bit about the type of instructions that we'll distribute with those projects. And what's very important about this, though, to understand is that, we may not be able to provide 150 translations of those, but what we try to do instead is to at least make it as clear as possible from a diagram perspective for anyone to do this on their own as a technician. Then finally, the last, one on the left, perfect. So the final type of project that we work on, and this type of project we're much less, we take much less of an active role, because what we're hoping to do is not develop or distribute these devices from the perspective of a nonprofit, which we are, but rather encourage our students to form their own startups and thus kind of encouraging the growth of the medical device industry that is catering and designed specifically with resource board settings in mind. There's a number of large companies out there that are slowly realizing that these emerging markets are very interesting for medical devices, but not necessarily happening at a very fast pace or in the best way possible for the countries in question. And so these are a few examples of some of the projects that we have that we've worked on with students. This project is second place in our design competition. Actually, I shouldn't repeat this. All of the projects that are here, pretty much all projects that are here will have come from our design competition, or if not for a project that matter list. This particular one is an ECG machine that cost, I believe, roughly $20 per full component. That was developed by a team of students in Mexico at a chapter that we have there. This is the prototype that came out when they won the design competition a couple of years ago, and this is actually closer to what it looks like now. This thing right here that you see is a different project. It's an uninterruptible power supply that is built with recycled components. So one of the components in there is an ATX power supply from a laptop. You also use a car battery in there, and all of this makes a uninterruptible power supply that can be used. Think of a hospital that has some kind of a surgery going on, and maybe the patient's life depends on a heart lung machine or some other kind of equipment to work. And very often we see blackouts and brownouts in a lot of places that we work, and so this is what would take over in case that a generator is not available or most likely too expensive because of the price of the diesel and the need to run it often. And so this is what we're very interested in seeing from our students, is really the initiative to do this, because these students have actually started their own pilot, and they're not students anymore, I shouldn't call them that. They started their own pilot in India, in New Delhi, and are currently working to implement this and go much further than that. This is a set of LED Billy lights that have been built in hospitals by Summer Institute and BMed students, but entirely developed by chapter students in collaboration with us. This particular example right here is this is just a circuit. This is the full project. This won last year's design competition, and it was as they call it, a low-cost blood pressure monitoring device that you connect to, an Android phone, a tablet, and I think they have software for using that with a PC and other interfaces now. And they're also continuing to work on this project. They're actually opening a pilot in Nigeria with a local nonprofit right now. So again, we're very, very excited to see things like this. And this is my final project that I'll be showing you. This is this year's winning team's design for the design competition. So something that was just announced a couple of weeks ago. And it's a very, very interesting design, because what they've created is a spirometer. So for those that don't know, a spirometer is what you use to determine a number of lung characteristics, mostly lung volumes. And what you'll do is you'll breathe into the outlet at the top, and there's a tiny little microphone that you see that is being used as a transducer, and they've managed to, with this $10 little thing, they've managed to consistently, with the results of their test, they've managed to consistently get within 5% of the actual tested volumes. So quite precise solution for a device that's very important and very useful in a lot of COPD and a lot of other diseases. And I'm sorry, this is just another one that I have. I'll just give you the name of that one. But that's an HIV treatment failure detection system that was developed by our team at UCSD, UC San Diego, and that came out of this year's design competition as well. And this one, this previous project, was from our team at the University of Wisconsin. I'm sorry, the Washington University in St. Louis. And so finally, how ways to get involved. I just want to go over this very briefly. If you're a professional, we're inviting you to become a BMed guest instructor. You can look at more details of that at either/BMETGI. We're also very, very interested in people who are interested in working as mentors for our chapters, so helping out with technical assistance, resources, and other things. You're also more than welcome to take on one of our Projects That Matter Design Challenge, which is available at either/PTM. And then for students, we have different opportunities available that include joining or opening a chapter. You can contact me for any of those opportunities that you emailed that's at the bottom. Or you can organize a kit build, take on a Projects That Matter Design Challenge as well. And one of the interesting things to do is to do that not necessarily as a thing on your spare time, but maybe to convince a professor at your university to do that, to supervise you while doing that as a capstone project or some kind of recognized university project. Or to finally enter the design competition or participate in the seminar. And that would be it for me.
Thank you so much, Julien. We really appreciate you joining us today and presenting some of this amazing work. Maybe if you could leave the slide before up. Actually, I can do it myself. Here we have it for those of you who are trying to see it. There's a few questions that have come in, and we're going to try to get to all of them. So I invite everybody to put your questions in the Q&A window. The first question is, what NGOs has EWH teamed up with? Particularly, there's some interest around what maybe in the engagement of EWH USA chapters.
Okay, so I see that there's also another question that came in just before that. So, Yana, if that's okay with you, I'll answer the one you just told me, and then the other one that came in right before that one. In terms of, oh, I'm sorry, that's actually not a question. Well, never mind. So, what NGOs have we teamed up with? We worked with a number of different partners. If you want to see a full list, because I mean, if I start giving you names now, there's maybe 30, 40 of them, and it'll just sound stupid. So if you want to see a full list, I'll type in the link to the page where you can see that right into the chat box. Let me know if you get my message.
Yeah, we can see that. Thank you, Julien.
Okay, there we go. So that would be for our partners. So I'm sorry, Yana, should I go for the first question then, or?
It's okay. We'll just, don't worry, we'll get them. The question that we have following this is, what are the educational prerequisites for people to be enrolled in your BMET program? Okay. According to this individual, we are working with a boarding school in Guatemala that is seeking vocational training options for their students.
Okay. So the important thing to understand in the BMET program, and I just want to make that clear in case it wasn't, because it sometimes isn't, we only train, in the Summer Institute, we'll train engineering students from, wherever, as long as they're interested in applying in the program. But in BMET, we're interested in training locals, so people that are indigenous to the country that we're working in. In Rwanda, we've been authorized by the Ministry of Health to bring in a number of, for the East African community, a number of technicians from hospitals outside of Rwanda specifically, but I'm not sure if we've received that authorization from other governments. I'm not entirely sure, and that's totally something that I can put the appropriate person, the interested party, in touch with. But it's not necessarily impossible, and definitely something that we want and love to do if possible, if we can. And now, in terms of actually adding, a BMET program to a country, that's a whole other, project, because it includes, finding the funding for a 3-year program, and a number of other things, of course, that go before that. That includes, the assessment parts of things and the curriculum development part of things, because of course the curriculum has to be adapted to the country in question. But the funding part is probably the hardest in general.
So related to that, a question came in regarding participation in the train the trainers concept for BMET, and would you say that that is all kind of related as part of that answer?
I'm sorry, I didn't understand that question. In what way are BMET guest instructors related to that?
So the question you just answered regarding the educational prerequisites for people to be enrolled in the BMET program, with respect to the actual training of the trainers, how can folks participate in that?
Oh, training of the trainers. So you mean getting, okay, so as a BMET guest instructor, you're actually not training the trainers, you're training the students directly. You go into the hospital, not the hospital, the location, generally the city that we're doing the training, and you'll be given a course of 1 to 2 weeks generally to teach, and you'll teach that directly to the students. And in the class, or maybe not in the class, but simultaneously, we're passing the program over to local instructors. So some of them might be in the class definitely to follow up, and if that's not their topic of expertise, to get more acquainted with it. But in general, that's something that we do as we progress and as instructors get trained. But as a BMET guest instructor, you train the students just as much, if not more, than the future instructors of the program once we leave the country.
Thank you, Julien. And that brings us to the end of our webinar. I want to be respectful of everybody's time, and I'd like to thank you all for joining us today. I'm just going to take you over to the slide where, for those of you who are looking to secure a professional development hour, the code is listed right there, and you can make sure to email us to receive your PDH hour certificate. I would like to thank Julien for his time in delivering this really thorough and insightful webinar. And of course, I want to, thank you, Julien. And I would like to invite everyone to join us for our next installment in the webinar series, which will be on September 11th at 11 with IDE, which will be quite revolutionary. So thank you, everybody. Please have a great morning, day, afternoon, wherever it is that you're experiencing it, and we look forward to having you join us on the next webinar in our series. Cheers.